Hi everyone. We are here in Glasgow, Scotland at EMS 2022, where there are over 1,000 participants with over 40 countries represented to all learn and share and think together about how to improve patient care in EMS. Prior to the conference, the Global Resuscitation Alliance met to discuss how to improve out-of-hospital cardiac arrest worldwide. We had leaders from over 20 countries put their minds together to measure and improve our systems, to share ideas, and to challenge one another to go farther together. The Global Resuscitation Alliance uses the 10 programs from the Resuscitation Academy to improve survival rates around the world. By working together and leveraging one another's strengths, we can solve problems and we can be creative in new ways. As a group, our objective is to improve survival by 50%. It's quite ambitious, and we've got information coming to you in this webinar, featured case studies on how communities are actually working towards that goal today. We're very eager to hear from you and what your ideas are, what your thoughts are about the work that we've got going on. So put your questions into the chat and we'll review a selection of them to discuss at the end. The Global Resuscitation Alliance is a collection of EMS leaders from around the world who use the Resuscitation Academy's 10 steps to improve out-of-hospital sudden cardiac arrest, to save more lives in their own communities and nations. For many years, EMS leaders and researchers have produced a body of scientific knowledge that's guided us along our journey. The Global Resuscitation Alliance takes that learning, that science, off of the shelves and puts it down onto the table, the kitchen table of EMS, to discuss together how we can use that science, implement that science to improve patient care. We've gathered some of our friends here from the GRA to tell you a little bit more about each of those 10 steps.
Step number 1 is to create a cardiac arrest registry. Our mantra is measure and improve, measure and improve. And what do we measure? We measure not just outcomes from cardiac arrest, but also key processes like bystander CPR, telephone CPR, and the treatment that goes on through our various providers in emergency medical services. Data is the key to improvement, and I always say that without measurement, there is no improvement.
So step 2, telephone CPR. It's important that we give our call handlers the tools to recognise early on in a call when a patient's in cardiac arrest to allow them to move straight on to give an effective CPR. We provide them with regular training and updates on telephone CPR and recognise them when a patient is in cardiac arrest. And we ask them to re-register for their licence every year, and they have to provide 24 hours to support the fact that they've done continuous education.
We know that CPR suspends the dying process. We also know that high quality CPR is a predictor of survival. When talking about high performance CPR, I like to use the analogy of changing a car tyre. We probably all know how to change a car tyre, and we could muddle our way through it to get the tyres back on the car. It could take us a couple of hours, and there might be bits that don't quite work out. In a Formula One racing crew, they change 4 tyres in 6 seconds. That's the difference between CPR and high performance CPR.
So step 4 is around rapid dispatch. Speed is absolutely of the essence in these situations, and rapid dispatch can add 5 to 10% to survival from out-of-hospital cardiac arrest in these situations. So what's really important is when the first critical symptom is identified, that a resource is identified and dispatched as quickly as possible.
Step 5. Measure professional resuscitation using defibrillator data. There's nothing like a real event to capture people's attention. One breath could be a gasp of excitement at a resuscitation done well, or a sigh at a resuscitation that hasn't gone quite so well. In my ambulance service, we use our defibrillator data to provide granular input into our cardiac arrest registry to improve future resuscitation, and also we use it to provide feedback, individual feedback on each resuscitation to our paramedics so that they can step by step improve their own resuscitation performance.
Step 6. Establish an AED programme for first responders. We all know the importance of early defibrillation in the survival from out-of-hospital cardiac arrest. And we know that when public access defibrillators are used, they massively increase people's chances of survival. However, we also appreciate that many of the public are still reluctant to use a public access defibrillation. Most of our systems across the world are working really, really hard to try and improve the public's confidence in using public access defibrillators. But what we would ask from the Global Resuscitation Alliance is that within your system, if you could explore other avenues in order to develop first responder schemes that would help early defibrillation. Think out the box. These could be things like asking your local police service to respond with an AED. Perhaps in some countries in the world that could be your fire service, or you could look, like we have in Scotland, for volunteers who are willing to be tasked to cardiac arrest at the same time while our EMS colleagues are tasked.
Step 7. Use smart technologies to activate bystander CPR. Imagine a man collapses at home and his wife sees that he collapses and calls 911. She's never had CPR training. But across the street, a nurse is having breakfast. How does that nurse find out that she needs to run across the street and start CPR? Apps like PulsePoint and Good Sam can be used to tell that nurse to go over and help perform great CPR to help save a life.
Step 8 is around mandatory defibrillator and CPR training for schools and communities. So many of the patients who arrest will do so at home, probably about 80%. So it's absolutely vital that somebody trained in CPR is available to undertake resuscitation. That may be a family member, it might be a child. Children from the age of 11 are well able to do CPR, so training those individuals in schools and in communities can save lives.
Step 9. Work toward accountability. We need to collect data in EMS and publish it to make it public so that we can keep score. We can use that information when we're doing well to celebrate our successes, and when things are not going so well, to help gain political support to get the resources we need to make it even better.
Step number 10. Create a culture of excellence. This perhaps is the most difficult of all the 10 steps. Creating a culture of excellence implies that everyone in your organization adheres to a high standard of performance and believes in the mission in delivering good outcomes for all our patients. It requires leaders with vision and commitment and people working together to achieve a culture of excellence. So one of the things we talked about was how can the Global Resuscitation Alliance move forward into the future. And we want to do a few things. Number one, we want to actually start to invest more in developing EMS systems, and especially those in low and middle income countries. And in order to do that, I think that we will need to relook at how we actually structure, for example, the 10 steps and make it more relevant for the context of different countries. And we want to also develop toolkits that will be of value and use to our partners that will help them to actually implement programs that can save lives. We also want to expand our reach to cover, for example, pediatric cardiac arrest, and even look at other conditions besides cardiac arrest, like trauma, stroke, or even perinatal mortality. So these are impacting us on a global scale in terms of the number of lives that we can save, because it takes a system to save a life.
Hi, I'm Belinda. I am Ambulance Victoria's current Research Governance Manager, And today I'd like to talk a little bit about high performance CPR and how we implemented an interventional bundle of education and feedback to improve patient outcomes. So Victoria has a population of 6.64 million people, of which approximately 5 million live within the greater metropolitan area. The unadjusted incidence of all out-of-hospital cardiac arrests in Victoria is 104 events per 100,000 population, and survival to hospital discharge following an initially shockable rhythm out-of-hospital cardiac arrests was 33.6% between 2016 and 2021. High performance CPR was introduced during that time frame in October 2018 due to growing evidence that this bundle of care improves survival outcomes. So when I talk about the intervention bundle, it meant introducing a checklist and a designated team leader to streamline resuscitation events, introducing resuscitation choreography that dictated team member roles, equipment placing, and intervention timing. We implemented on-screen rhythm analysis and defibrillations provided in manual mode with preemptive charging of the monitor, whilst continuing chest compressions to eliminate unnecessary pauses. Pulse checks were only conducted or are only conducted for potentially perfusing rhythms. CPR quality is guided by the use of real-time CPR feedbacks, which has both audio and visual prompts on the ZOL screen. And we've introduced post-event TPRs or team performance reports. Now, this intervention bundle aligns with quite a few of the Global Resuscitation Alliance 10 programs. Item 3, implementing high performance CPR. Item 5, using defibrillator recording. Item 9, being accountable. And item 10, providing a culture of excellence. So moving on to our team performance reports, which are central to increasing accountability and measuring success. For cardiac arrests, they are monitored by the Victorian Ambulance Cardiac Arrest Registry, which is VACAR, which reports back to executives and other members of the VACAR steering committee. Regional performance reports are distributed to the regional managers, but the TPRs, our team performance reports, are really our way of making sure that every paramedic on road has access to individualized feedback. So for each arrest, the target performance, which is the column on the left, is calculated as the top 20th percentile over the preceding 12 months of performance. And then on the right, crews will see what their actual performance was, which is shaded in percentiles. As well as this, they have access to the CPR metric screenshot. This comes directly from ZOL Online. And not only does it allow them to see overall what their CPR quality was, but you can see at each 2 minutes how that changes. So the individual paramedics can have a look at their individual feedback as well. As you can see here, you can see that changes how different team members have performed. So after we implemented this bundle of care, we had an increase in the level of monthly survival to hospital discharge with an adjusted odds ratio of 1.50, which is really quite profound. Our initial rollout has been extremely successful, and it's culminated in an additional 8.7 survivors per million population. Like all services, COVID-19 has disrupted all aspects of our healthcare over the past 2 years. However, we look forward to continuing to monitor and increase survivability from out-of-hospital cardiac arrests in Victoria.
Thank you so much for the invitation to share our program called Pakistan Lifesavers Program. And as you can see, it's about joining hands and saving lives. Let me begin by sharing with you the reason why we did this program. Pakistan is the 5th largest country in the world in terms of population. And our initial work has shown that every hour about 30 people die due to cardiac arrest and 10 due to injuries or trauma. And unlike high-income countries, many of these people, or most of these people, are younger. And we believe there are just a 1% reduction in these deaths will result in 10 lives saved a day in the country. And while these numbers are impressive, behind these numbers are stories of parents who lost their children and stories of children who lost their parents. And these are all preventable losses. And we feel these are losses that are happening without the society making a serious attempt to save them. And hence we started working on this program, the Pakistan Lifesavers program. And the vision is to make Pakistan a nation of lifesavers. Unfortunately, the country over the past decade or two has suffered significant civil strife, small-scale wars, terrorism, and we want to take the nation that has suffered from a lot of losses of lives to making it a nation of lifesavers by training the public of 10 million Pakistanis in the life-saving care for the patients with cardiac arrest and injuries. And the way we want to do it is broadly, the structure is we have our population trained in early recognition and activation of EMS, doing bystander CPR, or in cases of trauma, recognizing and stopping the bleeding, and doing the essential life-saving skills, supported by a dispatch-assisted CPR or dispatch-assisted stop the bleed, and then supporting the chain of survival through that. How did we do that? Our first step was to bring the major stakeholders together in the government, in the healthcare institutions, in the educational institutions, in EMS across the country. And an essential partner for this was the ownership of the state and the government. And then we started going to the schools and the high school and the college level, and started to engage the young boys and girls and young men and women in the care that is required for these patients. And we have gotten an outstanding, amazing response. Like any youth, the youth of Pakistan are eager to play their role, a positive role in society, take leadership, and also feel proud of their contribution to society. So, and as you'll see, it's not just the youth, the healthcare institution, our teachers are also extremely engaged, and they all want to learn because everybody has a story to tell. And as you will notice, most of these schools, our target is not just the schools with where parents are highly educated, where the teachers are highly motivated, where there is money and resources for this, but to actually target the schools that serve the regular people of Pakistan, and take them through this, what we think is not just a training in life-saving, but a leadership training experience. And as we move forward, we also felt the need to engage the law enforcement. As you can see here in this case, the traffic police who got highly engaged in this, and they took this as one of the key skills that they would like to learn. Also, women in multiple institutions and getting involved in this stage in certain areas. Broadly, we have about 30 to 40% of women as the lifesavers, and we hope to increase that number. And similarly, in colleges, we are seeing a major movement and excitement around this, and also the armed forces. So this really is making a fundamental change in how people are seeing CPR and stop the bleed, and how eager they are to learn this. And we are supported in all of this by our partners at the Resuscitation Academy. I'd like to appreciate and thank, and using, help us through the 10-hour, 12, 11-hour time difference, and supporting in training and measuring quality. So with that, I would like to just say that while our target is 10 million, we are very early in this journey. We have trained close to 100,000 people, all of them for free. And we have been keeping a track on who's getting trained at what district of Pakistan and what school. And we hope to, and one day, create a system where all of our lifesavers, Pakistan lifesavers, are connected to our ambulance network, and create a network of lifesavers, first providing bystander care while the EMS is on its way. And it does sound difficult and sometimes impossible in the context we are talking about, but as we know that it always seems impossible until it's done. Thank you so much for listening.
Hello, my name is Janet Trethewey. I am coming to you from Montana. My background is in education. I have a doctorate in education. That's what the EDD stands for. And I'm also a nationally registered EMT. In 2020, the state of Montana was given a very, very generous grant to provide AEDs for all law enforcement vehicles in the state. And that was a huge gift because Montana is a very, very large state. If you look at the relative size of Montana to Europe, you get a sense of how big we are. We are very, very low populated. This huge state has just over 1 million people in it. And so getting advanced care and getting help to people in cardiac arrest is very difficult. And so having an AED in every law enforcement vehicle in the state has really improved our ability to respond to those cardiac arrest emergencies. And so over the past 2 years, we've been implementing this project throughout the state, training officers in CPR and how to use these AEDs. You get a sense of the vastness of the state of Montana when you see all of nobody. In 2021, our cardiac arrest survival data indicated that we had 645 out-of-hospital cardiac arrests. The survival rate with good neurological outcome was almost 13%, 12.9%. This was an increase from 9.8% in 2020, and for the state of Montana was above the national average for survival. Our first responder AED use increased because we saw all these AEDs out in the field with our law enforcement officers. And because most cardiac arrests happen at home and nobody has an AED at home, having these officers get to people's homes very quickly made a huge difference. While we can't for sure say that AEDs in law enforcement vehicles was the only reason we saw an improvement in outcomes, we can say that we didn't do anything else to change the outcomes. That was the only thing that changed statewide. We have probably a better indicator of our impact for the first quarter of 2022. We had 40 cases that our law enforcement officers responded to. 38 of them were of cardiac arrest etiology, and we had a survival rate with those cases of 21%. We had 8 survivors, which 8 doesn't seem like a lot, but when you're talking about 8 families that were kept whole because of officer intervention, that's huge. Our officers have stepped up and are doing a great job with CPR and with using the AEDs when necessary. By monitoring our outcomes and our survival rates, we plan to see a continuation of this improvement as we move forward, because officers can get to the scene much faster because they're out patrolling versus an ambulance service who's stationary and has to get there. And so we're very excited about the project. We're very grateful to the grant people that got us the grant to provide these AEDs, and we just hope to keep moving forward to see better outcomes for our people in Montana.
My name is Gillinord, and I'm a pre-hospital emergency physician and also an anesthesiologist. I made a PhD about live video to the medical dispatcher, and here's my contact information, at least my email if you want to contact me. And here you can see the new chain of survival, where it's illustrated what has the greatest impact on survival, and that's the first minutes. It's about early identification, and it's about bystander CPR. We know that the medical dispatcher plays an important role when it comes to the bystander CPR, identification of the cardiac arrest, and also the use of an AED. To get more knowledge and information about the bystander resuscitation attempt, we collected CCTV recordings from public places where there had been a cardiac arrest and combined it with the audio from the emergency call to find out what was going on at the scene before ambulance arrival. What we learned from this study was that what was going on scene was not always what the medical dispatcher thought was going on, and the help or the guidance would potentially have been improved if the medical dispatcher was able to see the resuscitation attempt. In Copenhagen, Denmark, we have implemented that the medical dispatcher can watch the scene. They can receive a live video from the bystander's smartphone. We use it for evaluating the quality of CPR. And I'm now going to show you a video, a simulation video, about how it works.
Ja, hej, vi har brug for en ambulance. Der er en mand, der falder om her. Han er helt væk.
Hvordan trækker han vejret? Trækker han vejret normalt, ligesom dig og mig?
Der kommer så nogle små gisp.
I skal gå i gang med hjerte-lungeredning. Imens har jeg sendt en ambulance afsted med udrykning. Der er også en hjerteløber på vej. Er der nogen, der har modtaget undervisning i genoplivning ude ved jer?
Ja, det er der en, der har.
Hun skal sætte sig ned på knæene, ikke også? Og sætte hænderne midt i brystkassen. Så skal jeg bede dig om at sætte mig på højtaler.
Det har jeg gjort nu.
Jeg har sendt dig en sms. Du går ud af samtalen, og så trykker du på det link, jeg har sendt på sms'en.
Ja.
Så skal du give mig tilladelse til, at jeg må kigge på dit kamera. Det er rigtig fint. Jeg kan se, at I er i gang. Hænderne skal flyttes en anelse opad mod ansigtet. Længere endnu. Mellem brystvorterne. Midt i brystkassen. Ja. 1, 2, 3,
When you
4,
call the emergency
5,
number, a
6.
registered nurse or paramedic can guide you with a live video stream from your smartphone. They can help with patient assessment and first aid.
For 90 bystanders, we analyzed the quality of the CPR before the medical dispatcher used the video for guidance and after. And what we saw was that the quality of the chest compressions improved. You can see here the video illustrating the results. The quality of the CPR was evaluated subjectively from the videos, so of course it was a bit difficult to analyze exactly. Some parameters was easier to evaluate on the video than others. We also had a questionnaire to the bystanders about their experience with the live video. This is for cardiac arrest cases and non-cardiac arrest cases, but most of the callers had a positive experience with the video. For conclusion and perspectives, for live video stream from the bystander's smartphone to the medical dispatcher, we found that it can be used in emergency calls. It can be used to evaluate the quality of the CPR and potential also to identify cardiac arrest. In some cases, cardiac arrest was first identified when the live video was used. But now we have to find out how we should implement this in our protocols, how we should do that now we are unblinding the medical dispatchers. This is just a slide for further readings about our experiences and some publications. Thank you for listening.
So we just heard some fantastic case studies from our partners in the Global Resuscitation Alliance community. They really shine a light on some of the outstanding work that's happening around the world as we all strive to save more lives from sudden cardiac arrest. We heard from our friend Belinda at Ambulance Victoria on a bundle of training and feedback to improve high-performance CPR. We heard from Dr. Junaid Razak in Pakistan, who talked about the Pakistan Lifesavers program with an ambitious goal to train 10 million people in CPR and stop the bleed, leveraging, training for school children, healthcare workers, military personnel, and teachers. We heard from Janet Trethway in Big Sky Country, Montana, about the unique challenges of responding to rural cardiac arrest incidents and the way that they deployed law enforcement to help save more lives. And finally, we heard from our good friend Gitta in Copenhagen, Denmark, about leveraging exciting technology to bring video feed into the comm centers. So these are all examples of leadership in action and just incredible work that's been done. So Peter, I'd like to get your thoughts on the case study from Australia. I know that your system uses high performance CPR training and feedback. What were your thoughts on this case?
Yeah, I was impressed. You know, the question is always, does it work? And what Belinda and our Australian colleagues have done is broke down high performance CPR into those 5 essential components: early recognition, quality CPR, defibrillation, advanced care, and post-resuscitation care, and then applied the metrics to each one of those in really providing an individual way of evaluating the performance of CPR in the field. And more importantly, saying when you put all those together, does it make a difference in outcome? I mean, when we talk about these details, it really begs the question, if you put them into practice and implement them in a systematic way with training, scenario-based training, and then actual in-field evaluation, will it improve outcome? And the Australians put it to the test. And they observed across the board significant improvement, and actually about 9 more lives per every 100 patients treated, or I should say survivors per million population, in putting these ingredients together. So I was pretty impressed. We can talk about the 10 steps, but then the question is, if you implement them, does it make a difference? And that's what I took away from that.
I couldn't agree more. JT, what are your thoughts on this case study?
Yeah, it's impressive what people are doing with the 10 steps and what is influencing their daily work and their activity. And so looking at the good feedback, looking at the good information that comes and helps the providers is a very important step. And I think that is a great example, therefore, that other systems worldwide can learn from the experience and from the programs from others. And I think this is a big positive point of the Global Resuscitation Alliance, that we have a lot of perfect examples, maybe only fits in that way in that system, but you can transfer it, translate it to your city, to your country, and you have the chance to make it better and come back and discuss with the colleagues. So I was, as Peter said, really impressed by that activity. But to be honest, all the 4 programs what we see today are really impressive.
Yeah, you know, JT, I think you hit an important point, and that is it's not one size fits all, but it's adopting the principles that the 10 steps talk about and adapting that to a system. And the Australians tweaked a few things, no question about that. And that's appropriate because your system is not the same as our system, and but the principles still apply. And that's what's gratifying. When you put that in practice, it ends up saving lives.
And then there are groups among us that are pushing the boundaries even further, always sharing what they've done in the past, but really looking to the future. And, you know, and I think that story on the video feed into the comp centers in one of the comp centers in Denmark, you know, is one of those that is trailblazing. Michael, what were your thoughts on that?
Oh, and I agree. I was very impressed with, first of all, just making that happen. It's not trivial. Thinking about all the barriers that exist to doing something like that and convincing people that it's worth running the experiment. So that alone is an impressive accomplishment. And then the results they got were also quite impressive. I mean, seeing that almost every metric of bystander CPR got better with just-in-time coaching, right? So you had the caller and the call taker, and they're working together as a team to make sure that the person doing the CPR is delivering better quality CPR. And we know that telephone-assisted CPR or dispatcher-assisted CPR has a big impact. It improves the patient's chances of survival by roughly 50%. And that's a relative improvement, but that's an important thing. It's a big effect size. And I'm confident that by improving the quality of the CPR that the bystander gives, it'll bump it up even further. So I think this is great, and I'm looking forward to seeing additional centers try this out, and I'm interested in trying it in our center.
Mike Levy, do you think you might try that out in Alaska? It's someday in the near future?
Oh, we want to. I agree 100% with what Michael said and his observations, and I really just laud these folks, you know, the Copenhagen folks, the folks in Denmark, to have this much vision and to go through all the infrastructure changes and the training they had to do, as well as studying it. I think that's so important that they actually weren't going to just assume that things will work. I can tell you that in our system, and we're just looking at this today, truth be told, there's some challenges that we have. Our system, for example, it has basically untrained, non-medically trained people. We have dispatchers. We don't have nurses and paramedics like they do in Denmark. There's some infrastructure challenges we have. And believe me when I tell you that I'm not a naysayer on this. I think it's fantastic. And I think you know, people say maybe it increases dispatcher stress to see what's going on. But on the other hand, you know, I think it could decrease stress by actually being able to visualize something as opposed to blindly asking people with communication barriers and the like about important time critical events. So I'm really enthusiastic about seeing how this goes forward.
And Mike, I know that you know, your system, you know, is a mix. You know, you've got some urban response, but then rural response as well. And that next case study from Montana, I know that resonates with you. And I was wondering what you thought of the law enforcement AED as a way to, you know, expand that EMS response.
Oh yeah. So, you know, talking about a video telehealth, teledispatching, and now moving into something else, I'm kind of warmed up for my level of enthusiasm. I got to tell you that what Janet and her team did in Montana is fantastic. It just reemphasizes and tries to find a solution for what we know is that for these people that are salvageable 100%, that their life is draining away minute by minute because we can't get to them, not just with CPR, but with AEDs. We have basically a benign rhythm, VFET. Dr. Kudenchuk treats this day in, day out in the lab, doesn't lose people to it. It's a treatable rhythm if we can get to it in time. But our problem is that by the time our usual mechanism gets moving, even in an urban setting, it's very difficult to bring an AED to bear on the situation fast enough. But we have these mobile responders. We basically have this dynamic system of law enforcement officers who are out, doing their work on the streets, and just leveraging them in a big way across a big state like that to provide this life-saving technology for these, this one of the sine qua nons of a time-sensitive, life-threatening emergency, this time-critical emergency, and showing that they can get there and they actually save lives. This is fantastic. This should serve as a model for us all.
Peter, what are your thoughts on it?
I was thinking as Michael, you were talking, when you can't always do what you want, you do what you can. And I think in Montana, what Jana pointed out is the challenges that they have is they're not a large urban area. And so they take advantage of the fact that there are police out there and the police can roam. And they're not a full-fledged ALS unit, but they can provide CPR and defibrillation, the two elements that are the most life-saving ones we know of in managing cardiac arrest. And it says the resources that you have, you don't have to copy what Alaska or King County or what's going on in Germany we're doing. Adapt to the needs your own community has and take advantage of it. And that's what I saw in Janet's presentation in Montana. Good for them. They have now equipped police with the weapon against sudden cardiac death. And that's a great accomplishment, I think.
Well, just leveraging off what Peter said there, this idea of sort of weaponizing our police with AEDs, this is a total white hat issue for our police officers. Police get into police business because they want to help their communities. And this is just an extension of that. Police officers, our law enforcement folks, need to outfit every new squad car that comes in with a light bar, in America, a shotgun carrier, I guess, of course, but also an AED. Should be factory issue.
Amen, Michael.
And then talking about, meeting your community where it is, being resourceful, but yet being ambitious. I think, Junaid's story about the Pakistan Lifesavers program just speaks to that. In the most powerful way, this goal to train 10 million people, in early recognition and CPR, that speaks to the passion in all of us about about having big goals in this quest to improve survival. JT, what are your thoughts on the Pakistan Lifesavers Program project?
Yeah, and as you said, when you start with the headline training 10 million Pakistanis in CPR and bleeding control, everyone, I think, is impressed by that high number of 10 million Pakistanis. And if you see their results, what they have at the moment for maybe a city with 20 million inhabitants, it's Karachi, and they have a zero survival rate after 2 months. They saw the impact on being better. And the easiest thing is starting at the beginning of that chain of survival. So the idea of bystander CPR before the professionals can assist is, of course, well known in every of our countries. But I think the Pakistanis saw that it is not only for cardiac arrest, but also for trauma, a chance to lower the death rate and to higher the rate of people that survive. And I think they started in 2020 a fantastic program. And then, as a lot of programs will be interfered by COVID, has to stop or not to continue the process at the moment. But 70,000 people, that means users, but also teachers and multiplicators were trained. And again, when we talk about let's train 10,000 people, we will be proud of training 10. They will train 10 million people. And this is ambitious, but I think what we can do and what they saw from the others, there is a reason for training them. There's an impact on outcome. And so it is worth the effort. And I'm absolutely happy to see what they are doing there.
Michael, your comments?
Oh, I agree. I think just the way that they were creative about how to implement this program. And then I really also applaud teaching bleeding control as part of it, because in many communities that don't have the kind of resources that we're blessed to have, too many patients are dying, too many people are dying from bleeding to death from injuries that would be easily treated in other communities. So I think for a lot of lower and middle income countries in those environments, focusing not just on CPR, but on rescue breathing for babies and on bleeding control for younger people is going to have a big impact. Those teams in Pakistan have done great work in teaching the rest of us how to proceed.
So thank you so much for all of your comments. I wonder, just looking from a very high level at these projects and looking to the future, what your final reflections or words of encouragement for anyone out there who's looking to improve their system might be. Dr. Levy, let's start with you.
Well, thank you. Well, this is always very inspirational. It's certainly inspirational at this moment to see these videos, to see the projects people have embarked upon. Again, it just makes me personally feel small that I should be doing more all the time to see this going on. But we try. What I was impressed by is the vision, but also tempering the vision and enthusiasm with measuring, and actually building into it that basic premise within the Resuscitation Academy and that family of resuscitators that you just can't assume that video is going to work better. You can't assume that AEDs, if you put them on police cars, are going to have an outcome that you expect. So I think that's something that's, even as we kind of move into this space and have to move all the pieces around to get things to work, we still have to build into this some means to measure, to define what the outcome is we hope to expect from this, and then to measure it so that, again, we use our resources, our personal resources, our human resources, our financial resources effectively to kind of push this ball further up the hill to have more people survive from all types of not just cardiac emergencies as the Pakistani experience is, but also for other time-critical, life-threatening emergencies.
JT, your final thoughts?
Yeah, it is impressive what we see. And of course, we always talk about if you know one system, you know one system. Nevertheless, you can see in one system that fits there, but maybe you can just copy and paste, not steal it, but copy and paste and use it in your system. And as Michael said, to measure and improve, I think it sounds bad, but it will be a great motivation also for the Pakistanis when they come out with 0% survival at the moment. Anything what they're doing will have a great impact because they can see it directly that they have more survival, 1%, 2% in high-end systems. Maybe 1 or 2% sounds not great, but if you start at 0, it's a great step. And I expect that we will see a huge impact on all that programs. And what we saw also in the high sophisticated systems, name it AD, name it what happens in Denmark, and name it high performance CPR, are always part of the same puzzle, and it must fit the situation in that system. But again, Global Resuscitation Alliance is a global resuscitation alliance, so we can help each other, independent from the size of the country, independent from your results at the moment. And it is always, as Michael said, impressive, and we see what others are doing and investing in time and efforts to make more people at the end survive. And I'm happy to be a part of that group, and like to congratulate all the 4 presentators for that great project.
Michael?
Really not a lot to add, except that I was impressed that all 4 projects showed that each of the communities had identified one key thing to work on and then went after it and just kept with it, worked through these details, thought about the barriers, worked to overcome the barriers, and then made some really impressive gains for their systems. So this is not trivial. This took a lot of work in each of these cases. And kudos to those organizations and the leaders who made that happen. And I think for the people that are watching, do the same. Pick one project, not 5, one, and go to work on it and see in your own communities. I predict you will replicate similar successes.
And Peter.
Yeah. Well, I agree with both Michael's and with JT. You know, I took 3 lessons away from the 4 outstanding examples of application. One is that if you apply the basics, it makes a difference. The Australians showed that. And the basics aren't rocket science. They're basic principles that aren't flashy. They're not high tech necessarily, but they save lives. And that's application makes a difference. The second from the Danish experience is you push the envelope. You know, once you've applied the basics, how can you make things better? And becoming innovative with the whole concept of using technology to advance and enhance care in a community, and learn what we can take from those experiences. And then from both Montana and Pakistan, if you don't have all the resources, use the resources you have. In Montana, they took advantage of police to apply AEDs in the field. And in Pakistan, training the population in CPR and in the stoppage of bleeding. That's taking full advantage of the resources you have, which to me says anybody can do it. And it doesn't matter what sort of community or country or environment you have. Everyone can do something that will improve outcome from cardiac arrest. And we've had 4 great examples from the US and outside the US of how that can be done.
Fantastic. Well, that's all the time we've got for today. Thank you all so much for your contributions and for taking time out of your busy schedules to help provide some context and commentary. Hey everyone,
Thank you.
There are so many more case studies on our website, dozens of new case studies on our website. Please take time to check them out, share them with your colleagues, and then get in touch with us about your ideas on how to save more lives. Thanks.